So just to thank the Robertson for the invitation. This is a subject that's very, very close to my heart. It's something that I can really, like I said, can speak all day on. I'm going to try and keep it down to just a short 20-minute talk. It's a huge topic, so I'm really speaking on short snippets for each kind of stage of life. I could have filled the time easily with each of the small topics that I'm going to cover. So I'm going to cover just a little bit about puberty, what's normal, when should we worry about our daughters, specifically about daughters, because I am a gynecologist. Women that are preparing to have children, your childbearing years, go a little bit through the perimenopause and the menopause, and finish talking about screening for gynecological cancers, when one should screen for what conditions. So just a quick summary on normal puberty. So interestingly, these norms vary from country to country. So socioeconomic issues change these ages, psychological issues, exposures. So you cannot really apply these ages across the board. Each country will really have their own norms, but these are kind of an average of those. And initial signs of puberty would be breast budding, which happens around 9.5 in most cultures. And puberty then kind of ends with development of pubic hair at around 13 and a half years of age. And you'll see the milestone which is mostly associated with puberty, which is menarche, which is the first period, usually around 12 and a half years of age. So these are the normal kind of ranges that we should expect when you have a young daughter who's entering these years. So let's say you have a daughter who's approaching these ages and things are not progressing as you expected them to. When should you worry as a parent about your child? When should you seek medical advice? So the norm, we kind of say, is the absence of the first signs of puberty development beyond the normal range for a population. And in this country, we would say the absence of breast development by the age of 12 would be a concern. So if your child reaches 12 and a half, and there's been no changes in her body at all, this is the time to start worrying about your daughter. The absence of a period by the age of 16, if she's had normal sexual development until then. So if she's developed breasts and pubic hair and gone through a growth spurt and at 16 hasn't developed a period, then we should worry that there's something going on related to her ability to have a period. And these could be things like an outflow tract obstruction where a uterus is not connected to a vagina and things like that. So this is the time to start investigating these kinds of problems. And is there such a thing as going through puberty too early? Because we know that the age of puberty is getting earlier and earlier as young girls are exposed to things far before their time. And we generally say that a girl who develops sexual characteristics before the age of 8 or who starts to have a period before the age of 9, we would call this precocious puberty. So this is early onset puberty. It's not necessarily a problem. It's not necessarily dangerous, but it needs to be addressed because a girl may go through puberty before she's gone through her growth spurt. The growth spurt, if you remember a few slides before, will happen before the end signs of puberty, period, pubic hair development, etc. And if a girl starts to menstruate before she's gone through her growth spurt, then she's going to be stunted throughout her life. So if this does happen, we need to put the girl on growth hormones so that she can reach her height potential and not stay at the height that she was at 8 or 9 years old throughout her life. So these are the kinds of things to look out for and the kinds of things to be concerned about and to discuss with your doctor if these kinds of things happen to your daughter. So to move on a little bit to an older age and talk a little bit about fertility, which is really my number one topic and the thing that I spend most of my day thinking about and talking about. And we know that about 10% of the population will battle with what I like to call subfertility. There's very few limited cases of true infertility. A woman or a man may be subfertile, but infertile is a very, very definite diagnosis, and very few people will be completely infertile. And 10% of the population will struggle to fall pregnant. Those are the people that I'll end up seeing in my office. The one question I get asked every single day is, are there more people becoming infertile? We seem to know so many more people that are struggling to fall pregnant. And the reality is that true infertility, the incidence hasn't changed over the years. It still affects 10% of the population. But as our population grows, as our community grows, we know more people who are struggling to fall pregnant. But the one factor that we do see which is changing with time, and that is age-related subfertility. So there's an interesting statistic that I picked up at a conference in Madrid in June, that over the past 2 years, the number of women over the age of 40 who are starting to think about having children has increased by 160%. And this is the biggest factor that we deal with every day as fertility specialists, that we sit with a couple in front of us and it's just too late, unfortunately, for some of them. So a lot of what I want to concentrate over the next few slides is, can we do anything to preserve our fertility if we're not ready to have children yet before the age of 40? So just to take you a little bit through, I see that the slide isn't projecting very well, but one of the things that I speak a lot about is how ovaries work and how do men and women differ from a reproductive point of view. And I ask this question to patients. They all start thinking about superficially how we differ from a reproductive point of view, but there's a vast difference between men and women on a fertility level, and that is that men have a factory in their testicles that make new sperm every single day. A woman is born with her number of eggs. They age with her and they reduce as time goes on, unfortunately. So a man's sperm doesn't get old and it doesn't get fewer over time. But a man can have a factory fault in his testicles. So he can have a production line problem where not enough sperm is made, or the sperm is made with the incorrect shape and it can't move accordingly. But it's not that over time a man has a lower sperm count where his sperm reduces or his sperm ages. Whereas a woman, unfortunately, she is given her eggs for life when she's in her mother's womb, and that is a finite number. And it runs out at some stage in a woman's life, and we all know that. But before those eggs run out, even before menopause hits, their ability to create a normal pregnancy diminishes over time. And where do those kind of where does fertility start to reduce? So I always tell my patients this is a very, very scary slide, because for women who haven't had babies yet, it really can freak them out. But if we look at the slide, we are made to have babies between the age of 18 and 30 as humans. Humans are very poor reproducers. We've got a very narrow window compared to the rest of the species on the earth. But we're made to have our babies between the age of 18 and 31. And after 31, fertility reduces in a downward spiral, unfortunately. And that's purely related to egg quality, because eggs are more sensitive to aging than people are. And often I get asked in my office, why is it that women can live to 100 these days, but their fertility still disappears in their 40s? And it's interesting that we as humans, life expectancy has increased, but the fertility window hasn't increased as life expectancy increased. So if you think back 100 years ago, a woman would probably outlive her fertility. But we've now developed ways to live longer through medical advances, etc., and changing the way we live, but our fertility window hasn't shifted. So we still are made to have babies, you, between the ages of 18 and 30. So it's a very scary slide. And the other thing that we see from an age point of view is that as a woman ages, you'll see in the top right of the screen, pregnancy rates reduce. But as pregnancy rates reduce, abnormal pregnancies increase as well. So you may fall pregnant after the age of 35 or 40, but the incidence of miscarriage, chromosomal abnormalities, etc. increases. So what do we do about this? Because, like we know, the world is changing. Women are not having their babies between the age of 18 and 25 like they used to. So what can we do about it? So the one thing is to not delay starting your family too much. If you have met the right person, you shouldn't wait too long. But what if you haven't met the right person and you're just not ready? And we do have a technology today that allows for fertility preservation, where a woman can freeze her eggs and put her fertility on ice until she's ready to have babies. It's a technology that's developed incredibly over the past few years, whereas 5 years ago we said freeze your eggs, but maybe you will be able to use them and maybe you won't. And today we're confident enough to say if you freeze your eggs before the age of 32, you will be able to use 32-year-old, 31-year-old or 30-year-old eggs whenever you choose to have your baby. And the uterus is not so sensitive to aging. It's the eggs that are sensitive to aging. So a woman can have a baby in this country legally until the age of 49 with assisted reproduction. We are regulated. We're not allowed to make babies after the age of 49 or help people make babies after the age of 49. But a woman can freeze her eggs at 30 and have her babies until she's 49 years old. So if a woman is concerned about her fertility and she's reached a point where she's not ready to have babies, she should seek help and consider freezing her eggs. And that's just an interesting slide where we take donor eggs or eggs from a young woman and put them into the uterus of a woman who's much older, into her 40s, 48 and above, and you'll see the pregnancy rate stays exactly the same so long as the eggs are older eggs. Younger eggs. Good point. Thank you. It's not good for business if I say that. So one of the myths I wanted to talk about today is contraception and its role in affecting fertility, because unfortunately, I sit with a lot of people in my office who say, I was perfectly fertile, I went on the pill, and now I'm infertile, and the pill has caused this problem. So we know that contraception does not cause infertility. Hormonal contraception is protective against ovarian and endometrial cancer. And the next line is a little bit complex, but essentially what it means is when we've studied the hormone balance in women who've been on the pill for many, many years, as opposed to women who weren't on the pill for many years, in the same ages, there was no alteration in their hormonal balances. What the pill does do, though, is masks changes in your fertility, because when you have a period on the pill every month, it's a pseudo period, it's not a real period. So it's a withdrawal from the hormone that's in the pill, which causes a woman to bleed. And if she wasn't on the pill, she may have picked up changes in her menstrual pattern, which would have alerted her that something's going on. And that's where the problem comes in. We blame the pill that things have changed, but it's not the case. It's that something has changed in your hormones while you are on the pill, and then you stop the pill, and we have a problem that we have to deal with. So, when's the best time to try and make a baby? This is a question that I get asked also a lot. So now we're talking about women who are in their reproductive years and are trying to fall pregnant. And just to take you through that slide, that diagram on the left-hand side, but essentially what it tells us is that around the 14th day of a regular 28-day cycle is the time that a woman would ovulate and is the time that she's at her most fertile. So if a woman has a longer cycle than 28 days, this usually happens around the middle of the cycle. So shorter cycles, the middle of the cycle, longer cycles, the middle of the cycle. But in a regular 28-day cycle, around day 14 is when a woman is at her most fertile. And interestingly enough, we know that this is the most fertile period, and women that keep the laws of Mikvah, and I know part of what we're doing here today is for the Great Park Mikvah, and women that follow the laws of Mikvah and go to Mikvah around day 12, 13, which would be the norm if you count 5-6 days for bleeding and 7 days are clean days, that would take a woman to her most fertile period. So keeping the laws of Taharat HaMishpacha and Mikvah definitely contributes to better fertility. And the reason I say that is because I see couples who don't keep these laws from other religions or people who don't. And often the problem is just a timing issue, because if you're allowed to have intercourse the whole month, you kind of get tired of it in a way, and you're not doing it at the time that it's most important. So if you go to Mikvah, day 12, 13, 14 is really when we see intercourse is kind of concentrated around those days, which are the most fertile days. So for a couple trying to conceive, it's very important. What's also very important is that if a woman is struggling to get to the mikveh, so it's taking longer for her to get clean, or her cycles are very short, she goes to Mikvah and 4 or 5 days later she starts to have a period again, this is a very important sign for fertility problems. So a woman who's monitoring her cycle all the time because she's doing checks and counts and keeping a calendar is alerted to these problems much sooner than someone who's less conscious about her period. And I see that every day in my practice, that somebody will come over and say, I've noticed this has been happening to my cycle because I'm having to go to Mikvah much more often. So it's almost a good tool that a woman can use to alert her to fertility problems. And we've developed a program with a lot of the color teachers, the Chosin teachers in South Africa, where we talk about these things, and it's spoken to when girls are taught about doing their checks, that if you are struggling, speak to a gynecologist, because this could alert you to a fertility problem. The perimenopause and the menopause, the one that people don't like to talk much about, and this is also very much the age of perimenopause and menopause very much varies from culture to culture. We say around 45 to 52 is when the average population will go through this change of life, and any time before that would be considered abnormal. But we see young girls in their 20s who are going through menopause. And the way that they pick this up is that their cycles start to become shorter, so they're bleeding all the time, and they start to bleed mid-cycle, or their cycles disappear completely. And this is often associated with other endocrine disorders, so women who have autoimmune thyroid disease, lupus, things like that will often be faced with this very early menopause. But any menopausal changes or any signs of menopause under the age of 35 needs to be investigated, because it is associated with other genetic abnormalities that need to be investigated and managed if necessary. So when does a woman pick up that these things are happening? Like I said, your cycles start to shorten. So when a 28-day cycle becomes a 23, 22-day cycle, or suddenly when a 28-day cycle starts becoming a 50-day cycle, this would indicate these kind of changes in the menstrual cycle. Like I said, we see young girls who go through premature ovarian failure or premature menopause, and this is brought to their attention often when they find that they are going to the mikveh all the time. So moving on to screening for gynecological cancers, I will say that this is not my expertise, because I deal with the younger population, I deal with infertility. So just some credit to Dr. Marlene Botma, who's an excellent gynecologist who I work very closely with, who did help me with these slides, and I'd like to acknowledge her. The first thing I wanted to talk about was cervical cancer. And this is a cancer which is very uncommon in our circles, in the Jewish population, but it does happen, and everybody should follow the normal screening guidelines that are set down. Just because we're in a group that is less affected by this cancer doesn't mean we should miss these checks. So when should a woman start having her pap smears? So screening should start from the age of 21 in women who've already been sexually active. If a woman has not been sexually active before 21, there is no need for pap smears. So unfortunately, there's many gynecologists who are doing pap smears on women who have not been sexually active, and there is no need to do a pap smear in a woman who's not been sexually active. Women who have become sexually active after the age of 21 should have their first pap smear a year after what we call the sexual debut. Between the ages of 21 and 29, you all may have heard about this new thing called the HPV testing, which is the big buzzword at the moment. It's completely unnecessary in women between the ages of 21 and 29. The HPV virus, which is the virus which is responsible for cervical anal cancers, is incredibly prevalent in the age group of 21 to 29. It's not the kind of virus like gonorrhea or chlamydia that is kind of a dirty virus. This virus is very common, but we all have an inbuilt ability to clear this virus from our bodies. But if you test a person randomly between the age of 21 and 29, you've got a big chance of testing positive, but your body's constantly clearing the virus. Those that become susceptible to cancers don't have the ability to clear the virus like the normal population. So between 21 and 29, 3 yearly pap smears is absolutely appropriate, is absolutely adequate. You'll even notice that Discovery's changed their vitality points now. So you don't get points for a pap smear every year, and that's because more than yearly pap smears is unnecessary. 3 yearly pap smears so long as your last smear was normal. That's the key. If you've had an abnormal pap smear, annual smears is essential. Women over the age of 30 should start having HPV testing as well as pap smears. Because if the HPV is negative, then you can have you can be tested. If your HPV is, let me just put this right. If the HPV is negative, you can have a smear every 5 years. If the HPV is positive or you're not doing HPV testing, then your smear should be done every 3 years. So HPV co-testing over the age of 30 does have some benefit, because if you're negative, you only need to have a pap smear every 5 years. Screening is not recommended for women over the age of 35 who've had at least 3 normal pap smears, 65 who've had at least 3 normal pap smears in their lifetime. And women who've had an abnormal pap smear should be screened at least 20 years after their last normal smear annually. Women who have undergone a hysterectomy for whatever reason, where the cervix has been removed, there's 2 kinds of hysterectomies, a total and a subtotal. Subtotal will leave the cervix behind. It's important to ask the gynecologist what was done. If the cervix has been taken and the hysterectomy was not because of an abnormal cervix or an abnormal pap smear, there's no need to have further pap smears. If the cervix was left behind or there was an abnormality on the cervix at the time of the pap smear, then a woman should continue to have annual pap smears. Ovarian cancer, now this is something which is much more common in our communities and something more prevalent, and the current guidelines do not recommend routine screening for the average population. Who should be screening for ovarian cancer? Women who have tested positive for the BRCA gene. Now, the BRCA gene is a gene that is commonly carried in the Jewish community. And women who carry the gene are more susceptible to ovarian and breast cancers, amongst others. And these women should be screened annually, have a vaginal ultrasound and a CA-125 blood test if they carry the BRCA gene. If you don't carry the BRCA gene, should you be screened? Well, the question is, what kind of cancer history does your family have? And this needs to be discussed with a gynecologist. If there's a prevalent history in the family, then we should be screening for BRCA, and if we are positive, then we should be having annual screening for ovarian cancer. It's interesting that we're seeing a lot, as fertility specialists, we're seeing a lot of genetics work nowadays. And what I mean by that is a lot of young girls are screening for BRCA because their mothers, their grandmothers, their aunts have had breast cancer, and they're screening positive for BRCA. And we've got a technology today where we can make embryos in a laboratory, test the embryos for the absence or the presence of BRCA gene, and then only use embryos that are unaffected with the gene, so that the children born from this technology never have to worry about their annual mammograms, ultrasounds, ultrasounds of the ovaries. So it's important to listen to your family history. If you're concerned, ask the gynecologist to test you, and if you do come out positive and are planning a family, we can now ensure that your children don't have to have the same concerns that you or your mother, your aunt or your grandmother have. Endometrial cancer, also more common in our population, but not as common as ovarian cancer. Certainly not as common. Certainly more common than cervical cancer. Although there's no current guidelines on screening for endometrial cancer either. Women who are postmenopausal, so the periods have stopped for at least a year, and they have any kind of bleed after that, should be investigated for endometrial cancer, and that's the trigger. Any postmenopausal bleeding should be investigated with a vaginal ultrasound and an endometrial biopsy. Patients who are on certain hormone therapies for breast cancers should be screened annually. That would be your tamoxifen patients. And women who have never been pregnant, who are overweight, whose period started early, and have a high family history of colon cancer, these are women who probably should have an annual screen for endometrial cancer. These are the risk factors for endometrial cancer. So breastfeeding, pregnancies, absence of periods are protective against endometrial cancer. And certainly watching your weight, obesity is a very big risk factor for endometrial cancer. Obesity, metabolic syndrome, high cholesterol, high sugars, etc. This is one of the cancers that is very much of a lifestyle cancer, unfortunately. So it's one of those things that we have the power to change by watching how we live. Screening for breast cancer. Now this one is we all need to know about. We all need to think about, and everybody in this room should probably, everybody in this room should already be screening themselves for breast cancer. Even the youngest woman in the audience should be self-examining their breasts every month, at least on the first day of their period. If you don't know how to do it, go online. There's excellent videos. Or ask your gynecologist to show you how to examine your breasts on your own. But every woman should be examining their breasts every month at least. What are the risk factors for developing breast cancer? So, onset of periods prior to the age of 12, menopause after the age of 55, so longer reproductive years, having one's first child after the age of 30, never having breastfed, women who are using hormone replacement therapy, obesity, and dense breast tissue. Women should be accustomed, like I said, to examining their breasts at least once a month, self-examination, and any changes should be brought to the attention of their general practitioner or gynecologist. And like I said, a tip is to examine your breasts every month on the first day of your period. An annual examination should be conducted by a gynecologist, and this examination should take place irrespective of one's own self-examination. So even if you think everything's fine, allow your gynecologist or your GP to examine your breasts annually. From the age of 40, women should undergo yearly mammograms, and this should happen until the age of 70. This allows for early detection of lesions which may still be too small to palpable. And the key with breast cancer is early detection is the most important. And the reason why they say dense breast tissue, oops, wrong way, I don't know what happened there. Now I've lost the talk. The reason why they say dense breast tissue is a risk factor is because it can be difficult to feel the breast, which is a lump, which is deep. Any change to the skin on the breast, any change to the nipple, areola, discharge, pain should be investigated. I just want to see if I've left anything else out. I've lost the mouse, so I can't. The computer's told me that I've spoken for long enough. So I think that my last slide or two was just really summing up the talk. I've tried to condense as much as I can into a short space of time. I hope I've covered something for everybody in the room, and hope everybody has an easy fast and a good year.